Good morning, everyone. On behalf of Niramaya Arthritis and Immunology Foundation, Jaipur, I welcome you all for this virtual rheumatology meet in series of Rheumatology Clinical Pulse. And today's topic of discussion is large vessel vasculitis that will be discussed by Professor Debashish Danda. In first 45 minutes, Professor Debashish will discuss large vessel vasculitis, primarily Takayasu arthritis, that is the most common large vessel vasculitis in our country, and briefly giant cell arthritis, both cranial and extracranial, with or without polymyalgia rheumatica, and idiopathic otitis. I have requested Professor Debashish to teach us or give some clues to make diagnosis early in this difficult disease, and management tips, particularly monitoring, because it's very difficult to decide whether patient has symptoms because of disease activity or damage. I request all of you to type your questions in chat box, because in second half we will have question answers session. For that we have 45 minutes, and we have opportunity to discuss these questions with Professor Debashish. Then, regarding brief introduction of Professor Debashish Danda, we all know Professor Debashish. Recently, he was the scientific committee chair at IRACON Indore. He did his MBBS from JIPMER Pondicherry, DM from SGPGI Lucknow, advanced training in rheumatology from Royal Adelaide Hospital and Queen Elizabeth Hospital, Australia. He is International Fellow of American College of Rheumatology, Fellow of National Academy of Medical Sciences, Fellow of ICP, Professor and founder of the Department of Clinical Immunology and Rheumatology at CMC Vellore, past editor-in-chief, Eplar Journal of Rheumatology from 2012 to 2018, past president IRA from 2017 to 2019, and presently he is president of Eplar. Immediate past chair, International League of Associations for Rheumatology, ILR 2022, and he is convener of both Eplar and IRA Vasculitis Special Interest Group. Other than these, I would like to tell you one more thing. Here's the largest data of Takayasu arthritis in world. Recently, he published 900 patients data, 900 plus patients data in Cardiology Journal 1 month back. Before that, he published 602 patients data in Oxford Rheumatology in 2021 and 251 patients data in seminars in arthritis, that was in 2018. With this background, I request Professor Debashish Danda sir to start his lecture. Dr. Danda sir.
Thank you. Thank you, Dr. Vanvari Sharma. Thank you, your foundation, for inviting me to talk to the audience in this difficult time. And first of all, I express my solidarity with the struggle of the doctors which they are going through in Rajasthan and actually in all over India. It's one of the worst periods for the medical modern medicine doctors in India. So if my talk is coming on the way of your movement and fight for the rights, I'm sorry about it, but as we decided not to postpone it, and bear with me for the next 45 minutes. My talk, although has been titled as large vessel vasculitis, as Dr. Vanvari has explained to you very clearly, I will mainly cover about Takayasu and little bit about giant cell arthritis, and other things will be coming in the question and answer. So this is in the overview. First, I will mention the broad features and the broad outcome of both Takayasu and to some extent giant cell arteritis, and we will be explaining the various subtle differences between these two disorders. Although we have much more Takayasu's than very few giant cell arteritis in this country between the two large vessel vasculitis. I will touch upon the other vasculitis, large vessel vasculitis in question answer. Broadly, these are the two which are classified under classifications. So I will stick to that broadly. So I'll share my screen now on my talk. So this is a time-tested classification of vasculitis, and if you see that the broad, largely Takayasu and GCA are the two vasculitis affecting the aorta and its main branches at origin, whereas there is some large vessel component in a variable pattern in Behçet's and Kogan syndrome, which are now classified as variable vessel vasculitis. All the other vasculitis usually do not have large vessel vasculitis, although there are some smaller entities which we'll be coming on to describe a little bit. So this is the Hata's or Newman-O's classification. The yellow highlight or the orange highlighted areas very clearly describe the involved areas in the aorta and its main branches at origin to classify from type 1 to type 5, including type 2 subtypes A and B. So this is very clear. So as I've said, I'll be sharing some of my slides from my talk in the ACR some 2 years back. So we have classically these two, GCA and Takayasu, and also the other vasculitides, which are non-classic large vessel vasculitis, are mostly variable vessel. So this is a very recent review, came last year in search of commonalities. I have been involved with the ACR EULAR DCVAS classification of vasculitic disorders, and I'm one of the authors in the new classification of Takayasu. But I have constantly struggled within the group, expressing my views that these are two different diseases. They are not the two sides of the same coin, or nor they are in the two ends of the same spectrum. They are actually two different diseases. So this is what I'm trying to say. Over this paper, it tried to make a search for commonalities and trying to make some marriage between the two. And this review article is titled as large vessel vasculitis. So I would like to describe from epidemiology till clinical presentation, treatment, outcome, etc., including genetics and a little bit of pathogenesis later. But from this review article, which is the recent one, I'm showing this. So the GCA shown in blue, and in orange, it is the Takayasu. But I must draw your attention here. The GCA incidence is shown in per 100,000 population above 50 years, whereas Takayasu is per million. So, so the numbers which you see under GCA, to compare with Takayasu, you have to multiply with 10. So basically, you can see that so for example, in North America, you see that the GCA, so if you see in North America, the GCA, it shows 1 to 19.8. It will be actually 10 to 190 when it comes to million population to compare with Takayasu. So you can see that very clearly the incidence of Takayasu compared to GCA is extremely rare in the North American and Northern European population. There is not much of data from Africa and Middle East, whereas in South Asia, we have much more. Even if you multiply the GCA by 10, it becomes only 3%. So what happens, it is in focused population of South Asia, where we have GCA, actually not in South Asia, rather in Southeast Asia. So if you take the population of Japan, there is some, and on the other hand, Oceania, there is a lot more GCA than Takayasu's, whereas we have lot more Takayasu arthritis, although overall it's a rare disease in the community. So if you see, the same paper has explained the various common mechanisms and the various risk factors. So GCA little older patients, as we know, the HLA types are quite different, and Takayasu is predominantly class 1 MHC driven disease, whereas GCA is more of class 2 driven disease. Infections, I'll come to you, come to present to you some of the slides later, where you'll see even the trigger for GCA and Takayasu are different, and even the drugs causing large vessel vasculitis are also little different. But overall, they are trying to say that the pathogenic mechanisms may have some commonality, but then this kind of commonality is seen even between, say, multiple sclerosis and rheumatoid arthritis. It doesn't mean they are the same disease. So this is basically showing how the cascade of events producing the high expression of the cytotoxic or helper cells in Takayasu and GCA respectively, or sort of impaired expression of PDL1 or MMP9 expression, or aberrant Notch1 expression in T cells, endothelial cell and T cell interaction, the various actions of neutrophil and reactive oxygen species, leading on to the various types of T cell activation or T cell suppression, leading on to basal lamina and T cell infiltration, and also differentiated T cell production and endothelial permeability, leading on to propagation and inflammation in large vessel vasculitis. So this is a very broad, married concepts rather than the truth. So these are concepts
I think there is issue with audio.
well as severe than Takayasu. So the expression of various cytokines, the expression of various cells like in gamma delta T cells and the cytotoxic T cells, Th17 cells, which predominantly control the inflammatory process in the vessel wall, and leading on to aberrant cytokine production and overexpression of endothelial cell surface markers or the adhesion molecules and the ligands on the WBCs and the endothelial cells, eventually leading on to cascade of events causing intimal hyperplasia and damage in the media and adventitia and proliferation of the cells and infiltration of the inflammatory cells. So this is a picture which they try to say the broadly 4 classical presentation of various classical types of large vessel vasculitis. So if a 75-year-old man comes with unilateral headache, jaw claudication, lethargy, myalgia, weight loss, right temporal artery firmness and tenderness rather than palpability, then you need to do targeted evaluation for acute phase reactants, and sometimes on the ultrasound guided temporal artery biopsy or TAB. In addition, imaging like MR, CT or PET-CT or PET-MRI angiography. So this is also can be a different scenario this clinical scenario. And this is the story of story of cranial giant cell arteritis without large vessel involvement. And on the other hand, if the patient presents rather than cranial alone, more of a systemic presentation, say a 60-year-old man with weight loss, fatigue, night sweats, myalgia, initial investigations are normal, and there is some concern for large vessel vasculitis. We need to have, again, similar investigation, especially imaging, to look for large vessel subset of GCA. But if the same story is in a 30-year-old young woman with lethargy, anorexia, right arm claudication, mind you here, and uneven upper limb blood pressure, absent right upper limb pulse, then you have to again evaluate for acute phase reactants and angiography. And this is the story of Takayasu. So here, this clinical support scenarios explain a cranial GCA with or without visual symptoms, which is an emergency, or a predominantly a large vessel type GCA and a Takayasu story, which needs some of the evaluations are similar, but one of the things for sure is that they require often angiography. So this is a picture which shows a cranial GCA extent. This shows large vessel GCA extent. What is the Takayasu's extent here? What do you notice here from 0 to 100% is the extent or the degree of involvement. Now, unlike what we used to think before, now people are trying to say that the GCA actually has more extensive involvement of the aorta, not just in the temporal artery or in the polymyalgia or just the cranial vessels alone. They also have other areas. I will come to that subsequently, and we have now come to know that GCA may involve a wider area of the aorta and its main branches, but it is much milder. The extent may be almost similar, but it is much milder and much less damaging. On the other hand, Takayasu usually do not cause so severe acute visual loss, which happens in a subset of GCA. So Takayasu involves widely various aspects of the various parts of the vessels of the aorta. Now, this is a PET MRI imaging, which shows the first image, or the A, it shows the subclavian abnormality, subclavian narrowing, as seen in Takayasu, whereas the B, it shows also involving subclavian artery and the aortic arch and distal aorta in a GCA patient. And the last one is actually, it shows the rapid high definition imaging with or without fused PETs in a patient of GCA. So what happens is, it is trying to say that even GCA has widespread involvement, but not so severe. I will come to that later. So here again, the first one is a GCA, or large vessel variety of GCA, involving the angiographic showing the involvement of the vessel, and at 6 months and at 12 months follow-up points, B and C, and the last one is on treatment with tocilizumab. You can see the degree of inflammation and the uptake has significantly come down on tocilizumab treatment as in subsequent follow-up. So this is what is trying to show. Even though the uptake of FDG was much higher in the beginning, with treatment it comes down. Now, when there is a broad, it is from the same paper, the broad, broadly confirmed GCA, initially you start with a high dose of steroids, and they usually require lesser of second line agents, unlike in Takayasu's, and relatively in specific features when they are present, not in everybody, compared to Takayasu, you need to start, as you can see here, compared to this side. We are the first in the world to describe that concomitant and upfront second line immunosuppressant is very important. And that is how we can control Takayasu well. While tapering steroids, if you start the second line immunosuppressant later, the chance of relapse of disease is much higher. It gives time for the disease to bounce back. So therefore, we need to have that. If you can see the recent Springer textbook of biologics edited by Neeraj Jain from Delhi, I have given an algorithm how we manage Takayasu, like a treat to target pattern using ITUS and ITUS-A. And we can follow up disease activity, relapse or refractory disease, and how we can achieve sustained remission in most patients, more than 85% of the patients in long-term follow-up with upfront second-line immunosuppressants. More often we use MMF, but people also use cyclophosphamide, azathioprine, methotrexate, leflunomide, and of late JAK inhibitors also. Now, the laboratory investigation, these people have mentioned a whole lot of that, and I do not think we need all of these. Apart from the acute phase reactants, more often we do C-reactive protein than ESR. ESR may be more useful in GCA, and in the Western population, our country, the ESR is not the best way of going for acute phase reactant for two reasons. One is a lot of women are having low hemoglobin. Even hemoglobin of 11 and less can cause a rise in ESR. The second thing is we have almost perennially some or other infection in the community, which keeps the ESR to be persistently high because ESR depends on fibrinogen with a long half-life. It takes time to rise and even time to fall after control of inflammation. The other investigation mentioned here are in specific scenarios like you do electrophoresis in an elderly person and you suspect a malignancy, not in everybody. You do not require CCP, ANA, ANCA, etc., rheumatoid factor in most patients. Urine microscopy may be important, and sometimes because infective endocarditis in our country may be an important presentation. It can present at times like a large vessel vasculitis. Now, we have various disease activity tools. We are the first one to use Birmingham Vasculitis Activity Score, to use that as a template and derive the relevant items from BVAS to describe the DEI TAC for disease extent, and ITUS-A for disease activity of Takayasu. On the other hand, the NIH criteria, which was described much earlier than us, have not been validated. As you can see, both the DEI TAC and ITUS have been validated by us. We also devised a damage index called TADS, which has not yet been validated, but even before that, it is being used now in many countries. So, these same authors have described the various mimics of large vessel vasculitis. So most important mimic in our country is always infection. And among the bacterial infection, it is the infective endocarditis. I have seen several patients, at least 4 or 5 patients from my days in internal medicine to rheumatology, who presented like large vessel vasculitis with emboli, especially mycotic aneurysm, etc., mimicking like large vessel vasculitis. Syphilis becoming less common, but it can also cause aortitis, as you know, and tuberculosis have been always blamed, and tuberculous aortitis has always been suspected. Unfortunately, it has not been well validated or well proven by tissue diagnosis, etc. Various non-inflammatory congenital connective tissue diseases like Ehlers-Danlos, fibromuscular dysplasia, Marfan syndrome, etc., rarely neurofibromatosis, etc., can produce mimics of large vessel vasculitis. On the other hand, it is not unknown. Some of the rheumatologists have come across ankylosing spondylitis with aortitis or ascending aorta enlargement and aortic regurgitation. Atherosclerosis, Behçet syndrome, as I told you, variable vessel vasculitis. Dr. Banwari was mentioning about clinically isolated aortitis. a vague entity which may be a form of frusty of GCA in some patients, Cogan syndrome with interstitial keratitis and deafness and large vessel vasculitis. We also have the other rarely GPA or anchor vasculitis. IgG4 disease, a very close mimic of Takayasu's arthritis, and very rarely relapsing polychondritis like Ansmond. They can also have aortitis, and sarcoidosis is also another very important disease, very closely mimicking at times in a rare cardiovascular sarcoid where you can present with a granulomatous vasculitis. Lupus usually cause small and medium vessel vasculitis, but rarely can cause. Now, there can be also very important differential diagnosis is aortic coarctation. As you know, Takayasu and coarctation both is in younger patients, and Takayasu is also called reverse coarctation aorta. So coarctation should not be forgotten. Mid-aortic syndrome, where you can see the various prothrombotic complications causing extensive involvement of the aorta in occlusion of the major vessels, is a combination of thrombosis and vasculitis of large vessels. And you have the various histiocytic disorders like Erdem-Chester disease, radiotherapy causing fibrosis, something like IgG4 disease. They also can cause aortic fibrosis and causing stenosis and post-stenotic dilatation, mimicking Takayasu. And some of the immune checkpoint inhibitors predominantly cause various types of autoimmune complications. I have seen patients of Sjogren syndrome develop after immune checkpoint inhibitor. I haven't seen Takayasu with this. So these are some of the new things. Now, I have now described one of the latest publication. It's a review article, but they have very systematically described the data from various population and various publications, and mentioned what I have just now said. But is it really, can we really have a unified theory for GCA and TAC? This is my question. So I would like to have my contention that Takayasu is a different disease. It differs from GCA in terms of clinical features, in terms of imaging, classification, epidemiology, in terms of pathogenesis, pathology, genetic basis, and even treatment outcome. So if you see the older classification of 1990, as you can see that compared to GCA, Takayasu was originally classified below 40. The new classification now included up to 60. Although between 40 to 60, the prevalence is of all the Takayasu's is about 5 to 10%, not more than that. And again, you can see that the clinical features, of blood pressure differences, the brachial artery involvement, etc. The characteristic angiographic abnormalities more in Takayasu than GCA, involving more of temporal artery, very high dramatic ESR and dramatic response to treatment with PMR association. Now, age of onset, extremity claudication, headache, imaging, and histopathology are distinct and mutually exclusive criteria features for Takayasu arthritis. This is part of my talk in ACR a couple of years back, and I'm going to discuss some of these in next slides. But having said this, I would like to mention the latest classification which has come out. So the prerequisite to classify a Takayasu is that you have to have a suspicion of large vessel or at least a medium vessel vasculitis, because sometimes a large vessel vasculitis may not have symptoms. So because if you have a renal artery involvement, you may not have often much symptoms in terms of blood pressure or pulse. Rarely it can be blood pressure, but pulse differences may not be seen. Alternate diagnosis mimicking vasculitis should be excluded prior to applying the criteria, which I'm going to say next, which all of you might have gone through already. Just good to always revise. So this classification criteria, like most of the new classification criteria these days, has got a scoring system, but it has got two essential. Apart from the suspicion, as I mentioned to you, there has to be age less than 60 years, and there should be an imaging evidence of large vessel vasculitis, because for large vessel vasculitis, imaging is the gold standard. There is no other way of thinking of large vessel vasculitis. So if there is a female gender, get a score of 1, angina, get score of 2, limb claudication, score of 2, arterial bruise, score of 2, reduced upper extremity, pulse, score of 2, reduced pulse and tenderness of carotid artery, score of 2, blood pressure difference between arms and arms of more than 20 millimeter mercury, score of 1, number of affected arterial territories, depending on 1 means 1 territory, 2 means 2 territory, 3 means 3 or more territories, paired artery involvement, score of 1, and abdominal aorta plus renal and mesenteric involvement, score of 3. So a patient could be classified as having Takayasu with cumulative score of 5 or more points, with a sensitivity of 93% and specificity of 99%. So the reason why they have included between 40 and 60, even though it is very, very small percentage, it has increased the sensitivity from before. So that's what they argue, although I'm not very comfortable to diagnose Takayasu between 40 and 60. Now, as I told you, the absolute requirement is age and the angiographic vasculitic evidence, and additional criteria which I have already mentioned for female sex, angina, claudication, bruit, pulse, low pulse or absent pulse in upper extremity, carotid abnormality, and blood pressure differences. Additional imaging features: 1 artery, 2 artery, or 3 or more arterial involvement, symmetric or paired artery involvement, and abdominal involvement with renal or mesenteric. So these are the scorings which are given, and nowadays all classification criteria come in with scoring and thought to be more objective. So even for each of these items, they have described, although you need to have a score of 5 and above for evidence what is bruit and what is upper extremity pulse. They have clearly defined. You can go through it. It is available freely. It doesn't require a subscription. So this is the new classification criteria of Takayasu's arthritis. If you go to the giant cell arthritis, it is quite different. So the age at the time of, so there is going to be an overlap between 50 and 60, and they have deliberately kept it, even though I tried to argue in the group that we should exclude that, but they wanted to improve the sensitivity and they have done it. And you can see that it's a temporal artery biopsy is a requirement. There is no biopsy requirement. And if you have it, you get a very high score. You have still ESR and CRP scoring. You have visual loss, the high scoring. Then you have temporal headache, jaw and tongue claudication, scalp tenderness, morning stiffness in the shoulder and neck because of polymyalgia rheumatica. Association is present in 50% of GCA. But the corollary is not true. If you have a polymyalgia rheumatica, only 10 to 30% can have GCA. And abnormal temporal artery examination, which is thick and cord-like, not very pulsatile. Axillary artery involvement and FDG PET activity throughout the aorta. So this is the new thing, that GCA is not only restricted to temporal artery. There is FDA, there is angiographic disease involvement extensively, although it is mild. It's not as severe as in Takayasu, less damaging. So a score of 6 or more is needed to diagnosis, and you have to exclude an alternative diagnosis. Now, epidemiology, as I have mentioned, again, you see India, China, and Japan, and some of the countries like Brazil and Mexico are on the other side of the globe, who have more of Takayasu. On the other hand, the Norwegian ancestry, Northern European ancestry, North America, and Europe, and few the Australians who are of Caucasian ancestry, and the Japanese to some extent have some GCA. Otherwise, GCA is fairly rare, even though our colleagues have published recently GCA. Yes, it is not that we don't have GCA. I have seen in my whole of 30 years of career, only 3 GCA in CMC Vellore. Most of my GCA I have seen when I was in Australia. So I have not seen GCA that much here. Even here, if you see people are having 1 or 2 cases, being a busy rheumatologist, most of you might have seen 1 or 2 cases. But if you see, you would have seen 5 to 10 times or more number of Takayasu's. So as I've told, the Northern European ancestry is one for GCA prevalence, and Asians are more of Takayasu. You can see the prevalence in Northern Europe. I have already mentioned, and you see the Takayasu. You can see the GCA is more common in the European ancestry. The age I've already discussed. In a young people, GCA is a rarity, and similarly, the Takayasu more than 50 is also rare. In fact, it is much less when you reviewed recently. And the gender issue is more female predominance, almost 3 times more female predominance in Takayasu than GCA. Now, there are certain clinical features which are GCA specific, like polymyalgia rheumatica, which is shoulder and pelvic girdle stiffness, scalp tenderness, abnormal temporal artery, I have described to you, and visual disturbance. On the other hand, Takayasu, it is more of carotidynia, claudication, hypertension, pulse, blood pressure discrepancy, bruit, and rarely aortic regurgitation. Subdiaphragmatic vessel involvement and stenotic lesions related symptoms, response to TNF inhibitors characteristically differentiate from GCA, whereas constitutional features, cranial symptoms, acute phase response, angiographically long tapered lesions, and aortic wall thickening are more in GCA. So GCA has widespread vascular involvement. Thickening also does happen, but it is less damaging, which I'm going to come to and describe to you. This table also similarly describes the extent of vessel involvement, as you can see, and the age and the ethnic differences, etc. There are similarities. There are a lot of dissimilarities too. So if you see our patient, Dr. Vanbari, was mentioning, this we published a few years back. We have just published. I have not shown. That is more of a lot of cardiovascular emphasis given on the newer series, which we have just published a month ago in the American College of Cardiology Journal. And this is, we have seen that we have compared 602 between children versus the adult Takayasu, and infradiaphragmatic disease more common in pediatric Takayasu than in adults, and pediatric Takayasu more commonly present with systemic inflammatory features like GCA, and they have more favorable outcome, and longer duration of symptoms in Takayasu cause more damage. So this is the flow chart in our study, how we have included both retrospective and prospective arm, and we can see that the pulse abnormality is the commonest feature, and digital gangrene is the rarest feature. As you know, Takayasu, because of good collaterals, rarely have gangrene. There are a whole lot of other manifestations which are described in this bar diagram. The comparison of various clinical and angiographic features between childhood and adults have been compared. As I've told, fever is more common in pediatric, whereas claudication is more common in adults. Headache is little more common in children. Systemic hypertension is more common in children because the abdominal vessel involvement, especially the renal artery. Creatinine rise is more in pediatric. Often they remain undiagnosed for a long time. Aortic regurg is more common in adults. Cardiomyopathy more common in children who are younger onset disease. The left common carotid artery involvement is more common in adults. Right renal artery involvement is more common in children. Left renal artery is also more common in children. And coronary involvement is about 20% in adults, unlike in children. So this is the distribution of the vessels, which I have mentioned to you. The frequency of percentage of left subclavian artery is one of the commonest vessel involved in all our patients together combined, and angiographically type 5 or the extensive involvement is the commonest types of disease. Our patients had a disease extent was quite high, and also in children it was although it was comparable between the two, the most important differences was the disease was much more active in children, and both in terms of ITUS, in terms of ESR, and in terms of raised CRP. The children had more active disease. And complete remission rate was almost complete remission rate was much higher in children compared to adults, 87% versus 66%. There also, we have used much relatively lesser dose of adults, lesser dose of steroids for adults, 0.5 mg, and only rarely up to 1 mg per kg. In children, dose of steroid was little higher. That could be one of the causes for the better response rate. I'm not sure. We have also, as I've told you, all the features which I've shown you in the bar charts, pie chart, bar diagrams is shown in the table here again in terms of headache, abdominal symptom, BP, cardiomyopathy, etc. So now we also did a series much earlier, about 15 years back, on smaller series of pediatric Takayasu, and we found that there was at that time our patients had a little less outcome. Of late, the outcome is better because those days our treatment was less aggressive. So the angiographically, as you can see, it shows the vessels which are involved in the pediatric Takayasu. The renal was the more common in children than in adults, where the subclavian was more common. So now comes to the GCA. This particular series has very beautifully has shown the GCA features. So GCA can have a vascular, can have visual, can have constitutional, can have rheumatic features. So rheumatic, as you know, you can have PMR features, shoulder and pelvic girdle, muscle aches, morning worsening, and exacerbated by movement. Unlike other inflammatory conditions, it gets worse with movement. Whereas vascular disease with headache, scalp tenderness, claudication of the jaw and the tongue, more than extremities, and upper limb is more affected than lower limb vessels. The visual abnormality include anterior optic neuropathy, cotton wool spots, cilio-retinal artery occlusion, central retinal artery occlusion, cranial nerve palsy, and extraocular muscle ischemia. These are much less common in Takayasu than GCA. And systemic features like night sweats, fever, fatigue, depression, chronic dry cough sometimes, and loss of weight may be features of GCA. So in elderly person, apart from thinking of malignancy and tuberculosis, such symptoms you may think. So there are various risk factors for GCA which are different. As you know, the age, smoking. Takayasu smoking has not been shown. As you know, most of our patients are women, almost 10 times more common in women, and most of our women do not smoke. The low body mass index is predisposing to in GCA. Estrogen deficiency, that is in a higher age group. History of other vascular disease, in terms of various vascular symptoms. History of polymyalgia rheumatica, the HLA class 2, family history maybe there in polymyalgia and GCA. Gender, of course, female sex, but it is much less common than Takayasu's, and Northern European ancestry are some of the factors. So the potential differential diagnosis, unlike I showed in Takayasu, is a little different here. In case of GCA, because of the ocular symptom, the angle closure glaucoma, anterior non-arteritic anterior optic neuropathy can be differentiated. The regional causes like carotid artery, occlusive disease, intracranial pathology, migraine, cluster headache, trigeminal neuralgia, temporomandibular joint dysfunction, dental pain, and cervical spondylosis, especially because of jaw claudication, which may mimic because of referred pain in these conditions. Infections like herpes zoster in the eye, the varicella zoster, the otitis externa, sinusitis, and dental abscess can also cause referred pain in the similar distribution of jaw claudication or tongue claudication. The systemic conditions like multiple myeloma, amyloidosis, other vasculitic conditions like GPA rarely can produce features like large vessel vasculitis. The ocular GCA can again manifest in various ways, like anterior ischemic optic neuropathy and various other eye features which I have mentioned. Rarely, they can also cause choroidal ischemia, Horner syndrome, etc. And very rarely, they can cause ulcerative keratitis and scleritis. So This is a description of a large number of emergency admissions by GCA, and in which they have studied, then found the rheumatological symptoms like PMR features probably were the most common features for presenting GCA patient presenting in casualty, followed by cardiovascular and other manifestations, including infections due to chronic immunosuppression. So now I have described to you so far the broad clinical features of GCA and TAC. Now I'll go to the imaging features. As we can see here, the differences between TAC and GCA have been described in the darker bar diagrams are GCA and the lighter ones are Takayasu. And you can see that the left subclavian is sky high for GCA, they mentioned here. And although we have very high in Takayasu also. This is an interesting study which was published by heat map of large arteries and forming clusters of depending on the involvement of the vessels. This was using our patients and the NIH patients. They have studied and they have described 6 different clusters, whereas cluster 1, 2, and 3 are thought to be more common and TAC specific, 4, 5, and 6 to be more of GCA specific. So this is you can see the cluster 2, cluster 1, cluster 2, and cluster 3, and the arrows show the involved vessels narrowing as well as aneurysmic dilatation. So the Takayasu showing subclavian stenosis here, and cluster 3 it shows the Takayasu isolated stenosis, the left subclavian artery as shown here. And cluster 5 is a diffuse vertebral subclavian and the abdominal descending aortic involvement, and cluster 6 subclavian and aortic and axillary artery involvement. This is the characteristic feature of GCA. So cluster 1, 2, 3 was more common in the North American and the deceivers cohort. In the deceivers cohort, my cohort was the largest. Only cluster 6 was in the North American cohort, and the bilateral axillary involvement, diffuse vascular inflammation without associated damage is another feature which was seen in GCA. So now I'll give you a few 2 or 3 clinical examples of how I would like to share with you a few patients how they came in a very deceptive manner. This was a patient, a child I have seen probably 25 years back. The boy came at that time, was 10 years of age, with prolonged pyrexia of more than 3 months, with all the evaluation being negative, with oligoarticular large joint pain and swelling, treated with Penidior prophylaxis, and his fever continues to recur, and he was also found to have high right upper limb blood pressure when routinely blood pressure was checked by the sisters here. And because of that, because of non-response, we have auscultated and found, actually heard a renal artery bruit. There was asymmetric and absent pulse in multiple vessels. The angiography confirmed type 5 Takayasu, and also reappearance of pulse within 3 months of starting steroids with azathioprine. Those days we used to use a lot. And the patient then dropped out of follow-up and came after 5 years of Siddha treatment, stopping all our drugs. He had uncontrolled blood pressure, borderline rise in creatinine, headache and claudication pain, and patient was again started on immunosuppression, and he had to be stented in multiple vessels. With multiple complications he had, his creatinine was fully not stabilized. So this was one story, how a early Takayasu coming with fever can actually be very responsive to steroids, even reappearance of pulse, which has been described in literature. And this is one of the patients where I have seen myself this particular dramatic response. This is a story I'm recollecting from my medical college where I did my MD from. And this was in northern India, where a 16-year-old girl was admitted in medicine with intractable headache following a presumable meningococcal infection. Meningococcal infection follows in small outbreaks, happen in northern India in winter months. And the child was found to have feeble pulse. No blood pressure was recorded in the upper limb, and he was being treated in internal medicine as a shock following meningococcal. Although there was no rise in blood pressure in spite of escalating vasopressor agents for days with worsening headache. And the patient looked apparently alert and too good for a shock. And the lower limb pulse, while incidentally the consultant examined and found that the lower limb pulse was bounding, and the BP was checked, it was very high blood pressure in the lower limb. And the angiography was done those days in limited vessels of the abdominal vessels, and it shows a little bit of thoracic vessel was seen, and it showed that the significant renal artery stenosis. So this was another story how Takayasu can come. And in this case, some people even try to think of coactation, but because the upper limb blood pressure was not there, normally in the coactation is the upper limb hypertension is seen. It was not there. Otherwise, some were even suggesting whether it could be. So that was a very bright consultant who thought of Takayasu in this case. And those days they were given steroids alone. I'm talking of many years back. So this is another patient of mine, maybe about again 20 years back, a 35-year-old housewife. She was a case of ulcerative colitis or mesalamine, was well-controlled disease in terms of GI symptoms and other systemic features. And she was given initially steroids and azathioprine. As she was doing well, she was stopped from steroids and azathioprine, and she was only on mesalamine, 5-aminosalicylic acid. And she developed then progressively worsening hypertension after stopping of steroids and azathioprine. And she had bloating and abdominal pain after food, in spite of ulcerative colitis symptoms under control. I was those days in medicine, and this patient came, was admitted under medicine, and then I saw, and then while I had a habit of looking at pulse in both hands, and I found those significant discrepancy in pulse and blood pressure also. And she had complaints of the neck pain, which everybody ignored. And actually, she had carotid tenderness on examination. So again, we did an angiography in this case. It was type 5 Takayasu, and she had improved on immunosuppression. This is a patient from Gujarat, a diamond merchant, 38-year-old gentleman. He came with cardiac failure and ejection fraction of 20% with weak pulses to a local doctor in Ahmedabad. And he was treated as a myocarditis with steroid pulse and recovered slowly, and he was on oral steroids. Subsequently, while his cardiac failure function improved, he developed eventually after months severe aortic regurgitation and hypertension and seen by cardiologist. And he had angio showed aneurysmal dilatation and narrowed segment in aorta and renal artery stenosis. On tapering the steroids, again, he developed breathlessness, and the cardiac surgeon there did an aortic valve replacement, and patient improved in terms of cardiac failure and other symptoms of breathlessness. Again, after several months, he's worsened, and his doctor he fortunately saw a good rheumatologist in Ahmedabad, and he had feeble pulse, and immunosuppression was started, and it had improved. He again had to be given. This time he developed myocarditis features again with ejection fraction of around 18%, came to us, referred by the rheumatologist in Ahmedabad to me, and it was confirmed type 5 Takayasu, and we had given IVIG. Coronaries also were affected, and we maintained her on steroid and MMF, improved very well. Gradually, the patient had stopped MMF, and then he developed an acute myocardial infarction in Ahmedabad. And he had undergone CABG, followed by again immunosuppression was started by the rheumatologist. Again, patient improved. I had a telephonic conversation with this patient about a month ago. He was doing well on MMF until few months ago only. So this is a story how even a bad Takayasu with cardiac involvement, with aortic regurgitation, with myocarditis, with hypertension, refractory hypertension, patient can do well on treatment. And every time he worsened when he stopped his immunosuppression. Now, little bit about histopathology I would like to mention. Now, GCA and Takayasu have significantly different histopathology. The inner media and the intima are the predominant sites of inflammation in GCA compared to Takayasu, where there is a more of adventitious fibrosis than the other two layers. The fragmentation of the internal elastic lamina is seen in GCA, and well circumscribed intimal fibrocellular hyperplasia is seen in Takayasu. And focal aortic wall inflammation with skip lesions are seen in GCA, whereas increased vessel thickness is seen in histology in patients of Takayasu. Now, in pathogenesis, microbe connection has been blamed for almost all rheumatic diseases and more commonly in vasculitic disorders. So in Takayasu's arthritis, as you know, mycobacterial theory is very old. On the other hand, GCA, it is Burkholderia, which has been blamed more often. In Takayasu, the molecular mimicry with Mycobacterium tuberculosis and gene sequences have shown in tissue and aorta with increased T cell response to heat shock protein 60 and 65 are some of the evidence of mycobacterial trigger. It's not infection, it is the trigger.
Sir, last 5 minutes.
Yes, thank you. And pathogenesis of exogenous antigens like mycobacterial tuberculosis, apart from heat shock protein, also PRP, the adventitial involvement with antigen presentation, T cell activation, and recruitment. Media is, as I told you, giant cell granuloma formation may be there, intima damage by cytokines from recruited cells can happen, and vascular remodeling by vascular endothelial growth factor and platelet-derived growth factor are some of the oversimplified description how the vessel wall is damaged in Takayasu. In GCA, chlamydia pneumoniae and varicella zoster virus have been also blamed as potential triggers, and Th1 and Th17 activation more activate median endothelium, as I mentioned. And there's no gamma delta T cells and NK cells in GCA, unlike in Takayasu, which is more common. In fact, there is more of CD4 cells in GCA. And there is also microbiota in the pathophysiology of Takayasu and GCA, and TAC patient poses unique microbiota as marked in green. And this study has shown that the microbiota varies. A fibroblast growth factor 2 also can differentiate Takayasu from GCA, as it is shown, and it can also differentiate type 5 Takayasu from other types of Takayasu. Here again, heat map of immunophenotyping of cells in response to treatment during follow-up in GCA on the left side and Takayasu on the right side have shown, and it shows the CD8 positive T cells do not change from baseline through remission or relapse with treatment. It is more so in Takayasu's than in GCA. And as you can see, there have been many genetic studies have been shown. DR4 is more associated. More in DR4 is more common in GCA, whereas HLA B52 have been more found in Takayasu. There are also other various genetic markers which have come up in Takayasu, including IL-1, IL-12, IL-6, and IL-18 genes in Jiva studies, etc. So as you can see, B52 and B39 is more in Takayasu, and DRB1, O401, and O404 in GCA, and most common in the America, I have up to 60% of the Americans have this haplotype, whereas we have 56% of Takayasu has in general B52. We also have the odds ratio of DRB1, O4 in case of GCA, and also HLA B52 odds ratio of 2.3 to 2.5. And again, Takayasu GCA is less common in Japanese, especially this particular HLA molecules. And again, Japanese have more HLA B52 and IL-12B. The non-HLA genes are also, there are 5 non-HLA loci has been described in Takayasu, like including the FCGR2A and GCA-PTPN22 has been described. These are other different 5, including IL-12, IL-6, etc. And GCA also, there is also other biomarkers susceptibility loci. So there is also various common genetic components in large vessel vasculitis through meta-immunochip studies. It shows that GCA is a predominantly class 2 MHC disease and Takayasu is class 1 MHC disease. The treatment of GCA, the meta-analysis, if you see that the tocilizumab steroids benefit clearly, whereas methotrexate, abatacept have some effect, and TNF inhibitor has no effect on GCA, unlike they do good response in Takayasu. So if you see the aggressive treatment improves outcome in Takayasu, the few lessons I would like to, please give me 5 minutes more, is few lessons which I have learned I would like to share. One is the lower initial dose of steroids may be as effective. In Takayasu, there is no need to give 1 milligram per kilogram body weight of prednisolone equivalent in the beginning. You can get the same benefit with 0.5 mg per kg per day. Even the Chinese have shown the similar. And we have found the slow tapering has a better response rather than rapid tapering. If you do rapid tapering, you can actually have a more relapse and eventually you will end up giving more steroids cumulatively. Then it has also been shown that the steroids plus second line immunosuppressant actually improve, causes better, almost 3/4 have remission if it is started upfront. So this has been shown in several studies. Also, the immunosuppression actually minimizes the development of various other complications and new lesions, which has been shown in multiple studies. New arterial lesions in Takayasu during 5 years, if you see, it is more common when you use steroid alone. It is little better in the DMARDs, also is also used along with steroids while being tapered, and TNF inhibitors gives a best response. And immunosuppression improves the outcome of revascularization procedures. You know, almost 2/3 of patients on revascularization stenting, they can actually have restenosis, but this is much less when you use immunosuppression prior to that. And immunosuppression improves survival significantly, as low as 0% in some population. And multicentric studies, including French series, also have shown that gradually with immunosuppression, overall outcome 5-year and 10-year survival is improving a lot. So the long-term outcome of prognostic factors in Takayasu arthritis is significantly improving when you are using patients with more aggressive treatment. And this is our study which published in Seminars in Arthritis and Rheumatism many years back. Actually speaking, 251 patients, an average follow-up of almost 10 years. And we have seen when you do treat to target like approach using ITUS A, and you escalate the treatment and you change the agent when it is refractory, eventually only 15 out of 251 patients were truly refractory. All the other patients who were relapsed or did not respond had improved with the higher dose or change of immunosuppression. And you can see here over the follow-up period, over more than a 5-year period, you can see that between 60 and 80% patients can do well if you closely monitor. And you can see the survival, even relapse-free survival, even at 10 years, it can be close to 50% of patients. And if you see here, the comparison of outcome, the relapse-free survival has been gradually improving in all the countries, and it is worse in those countries who use steroids initially, then the taper, then they start second-line agent. They actually have a worse outcome, and those who do not use second-line agents, they have the worst outcome. So Takayasu, ultimately people have found out that ultimately whether the TNF and IL-6 are the predominant cytokines causing the endothelial and the media adventitious damage. Therefore, blocking IL-6 and TNF inhibitors are a good option, whereas the normal synthetic DMARDs do improvement, but they are non-specific. But TNF blockers, IL-6 blocker, IL-17 blockers, and isolated cases, rituximab also has been found to be useful. People have studied the TNF inhibitors with good success, and people have actually found that tocilizumab, actually, even though primary endpoint was not reached here, they have a lesser or a delayed time to relapse, a longer time to relapse compared to the placebo. Abatacept was useful in GCA, not in Takayasu. And this study also have shown that management of Takayasu arthritis, when you do the systematic review and the EULAR recommendation of large vessel vasculitis, they have actually found that the glucocorticoid with other agents have a better outcome, lesser relapse, and efficacy of biologics treatment outcome in a multicentric response. It shows that the biologics probably have a better outcome. There was no difference, however, between TNF inhibitors and tocilizumab, although we find tocilizumab much more convenient to use, and subcutaneous tocilizumab have been very effective in many patients we have been using. The disease assessment.
Sir, we have a lot of questions.
Okay.
I'm just finishing. 25 minutes only.
Okay, we have last slides now, last 2 slides. So these are the investigation I have mentioned to you. I will not go into that. And disease activity, I just want to mention that NIH criteria was not validated. The BVAS was the mother of DEI talk for extent, ITUS for activity, TIDS for damage. And we have validated this and published in Oxford Rheumatology years ago. And this is followed everywhere, ITUS. And first visit is sometimes challenging. I will explain to you during the question. It can be sensitive to change, and the patient worsens or patient improve. It is sensitive to change. The last slide is that it shows how over the years the mortality from 16% has come down to very low percentage over the years with aggressive immunosuppression. So what I am trying to say, Takayasu and GC are two different diseases from womb to tomb. So they are not the same disease, and I would like to discuss the rest in question and answer. Thank you very much for your patience.
Thank you, sir, for excellent talk. You have covered everything about Takayasu arthritis, and you have given differences from giant cell arthritis and covered the polymyalgia rheumatica part also. We have some questions, clinical questions. The first question is, a young female, 32-year-old female with recent onset hypertension, right arm claudication, absent right radial pulse, ESR is normal, CRP is near normal. What is the imaging modality of choice for diagnosis in this patient?
Very good question. In fact, I would like to mention one thing here which I could not say. The ESR and CRP has been found in active Takayasu's where histology proven, when the patient had gone for surgery, say for aortic valve replacement, they have found the disease is active histologically with infiltration of the active inflammatory cells. They have normal ESR and CRP. So ESR, CRP may not reflect the disease activity about 50% of the times. So that's why we have disease activity score. You must do an ITUS score, and certainly angiography should be done. Now, which mode of angiography? Actually speaking, if you have a skill, the cheapest option would be ultrasound Doppler, but it needs a lot of skill. Everyone cannot do that. And the Calcutta colleagues have designed a very good Calcutta the ultrasound score for Takayasu's, which you can use, which has been published again in Oxford Rheumatology. But in my patients, what we do is now, earlier we used to use a lot of conventional angiography. It is probably the best resolution, although it cannot define the disease activity. CT angiogram, especially 3D reconstruction, have been found to be a little better in terms of disease because it can actually show the vessel wall thickening. And in a chronic inactive disease, it may show some thickening, but more of calcification. MR angiography, we have published a series of MR angiography showing the vessel wall involvement or activity in vessel wall correlating with ITUS A score. But again, it's not well studied in a larger population and validated. PET-CT or PET-MRI is probably the best in first time. Unfortunately, cost is a limiting factor, and there is lack of consistency of PET-CT and PET-MRI in assessing disease activity in multiple studies. Although one thing has been agreed upon is that initial visit, like in this girl you have mentioned, for the first time, PET-CT or PET-NGO maybe PET MRI may be a very good option for assessing disease activity. In the long run, in follow-up, PET CT or PET MRI is not a good option because it can actually give a false impression because of various factors. So in the first visit, a patient cannot afford anything. If you have a good radiologist, you can do an ultrasound because most large vessels can be visualized, but it will not be an exhaustive done because intra-abdominal vessels may be difficult to do by ultrasound Doppler. Although now there is a contrast Doppler in some centers, it needs expertise. So CT angiography, I would say probably the best option in terms of activity as well as extent of disease. If you do not want to assess activity by angiography, vessel wall status, then conventional angio is good, but it gives a lot of contrast. Same is CT. MR angiography gives a safer contrast, lesser contrast, and it may also show the disease activity very well. And MR angiography is in many ways good because the contrast is usually not nephrotoxic so much. And the advantage of MR angiography is, even though the resolution of the MR angio and the peripheral branches are not very good, it doesn't matter to us, because in Takahashi what matters, or the GCA what matters, is the aorta and its main branches at origin. So those branches are better seen, quite well seen by MR angiography. That serves our purpose. So you have to design which angiography you will do, but angiography is a must, whether you should do PET CT MRI or CT angiography or MR angiography or conventional angiography or a ultrasound Doppler. Depends on the patients and your convenience. Thank you.
The second thing, yes, sir. The second thing is, should we screen for all major vessels at baseline to see the extent of the disease?
All major vessels?
Yeah, how to see the extent of the disease in this patient?
Yes. So actually speaking, as you've seen the new criteria now, angiography is a must. Although it is a must, we know the difficulties of many of our patients. It is expensive, there are contrasts, all that. So if you really have to see all vessels, I would recommend a CT angiography, or if not, a conventional angiography. On the other hand, we have disease extent index, the clinical score, which is also good for follow-up of the patients to know the disease extent in the beginning and subsequently how the extent is done. So you can do DEI tag score, and you certainly need to an angiography which sees all the vessels. In that respect, to see all vessels, vessel involvement or the extent of the vessel involvement, ultrasound is not that way a very good option, because you cannot see all the vessels with ultrasound. It needs a lot of expertise. All the other angiography can see very well as far as large vessel vasculitis is concerned.
So basically, suppose we go for CT angio or MR angio, we have to go for the aortic arch and its branches. We have to go for the renal vessels also. We have to go for the extremities also.
Absolutely. From the ascending aorta till the division into the iliac vessels, we have to actually see whole of aorta with the branching, because otherwise you will miss type 5. If you see type 5 classification, even by classification by Numano, there are some drawbacks. If you have a infra-abdominal vessels and you have a patchy involvement in supra-abdominal in the thoracic and aortic arch, it will be still called type 5, because it does not have to be continuous involvement. So you will miss it, the patchy involvement, if you don't do an extensive angiography.
Okay, thank you, sir. So next question is 42-year-old female, diagnosed patient of Takayasu arthritis since 2012 on immunosuppression. She's on 5 mg of prednisolone plus azathioprine 2 mg per kilogram per day. She's having often on mild neck pain, ESR 42, CRP 12 mg, and this is in the same range since 2018. Previous MR angio showed vessel wall edema, narrowing, and at places stenosis at right subclavian and brachial artery in 2018. What should be the best course of action therapeutically in this patient at this moment? Number one. Number two, should we repeat MR angio to assess vascular damage? Number three, how to assess damage versus activity on imaging in this patient?
So very good question, a very practical question. This is an example of a case which has been poorly immunosuppressed. This has been poorly immunosuppressed and poorly assessed for the follow-up for the status of disease control. So this patient either might have been given very rapid tapering of steroids, suboptimal dose of this azathioprine, or the patient is not responding to it. The very fact that ESR CRP continues to be high, the very fact that the baseline MRI had vessel wall edema, and the patient has a high ESR CRP now, it shows that the disease continues to be active. I would like to emphasize here that a poor control of inflammation is as good as no control, because the damage will continue to progress in other areas also. So there are two options to it. How I control an active disease, a persistently active disease, either it is persistently active or a new reactivation. It can happen even in the patient who was very well controlled for years also, it can come back. So in those cases, the first option, the cheapest option, is you have to give high dose steroids. High dose means 0.5 milligram per kilogram body weight of prednisolone or equivalent of deflazacort, which I use more often. Second, if the azathioprine dose is only, if the patient cannot afford more, you can go up from 2 milligram per kilogram to 3 milligram per kilogram, up to 3 mg per kg, if there is no contraindication. The third, if you want to spare the patient from high dose steroids, if there's some contraindication like diabetes or other issues, I would go for tocilizumab. It's a wonderful drug for acute control of disease activity. I have seen, and you must, all of you must be having experience on tocilizumab, whether it is a rheumatoid or in Takayasu. It just controls the CRP in no time. In 2 weeks' time or 3 weeks' time, you'll find, or 1 month time, the CRP comes to 0 or even close to 0, below 5. So I don't use tocilizumab forever because I know it is expensive. Even though the cost has come down significantly, I use as a stopgap measure. We are the first in the world to publish series of tocilizumab in Takayasu for acute control of disease. We concluded 3 things here. Number 1, tocilizumab is rapidly acting in controlling disease activity. Number 2, tocilizumab is steroid sparing. And number 3, even after 6 months of tocilizumab, you stop the tocilizumab, disease bounce back. We tried initially without any other second line agent. So even if you give tocilizumab, you can initially, suppose you're on high dose steroids, within 2 weeks, you can drastically cut down from 40 milligram prednisolone to you can come down to 6 milligram or 5 milligram if you have given tocilizumab. If it was for the first time in an Addisonian dose, so the patient doesn't go into Addisonian crisis. So you can cut down steroids very drastically. Number 2, if you are starting for the first time in this patient, if the patient can afford, I will give tocilizumab 162 milligrams subcutaneously, or you can give 8 mg per kg IV. Subcutaneous is more convenience. Initially weekly, and moment the CRP starts declining, within 2 weeks' time, I space it out to 2 weekly, and then 3 weekly, and then 4 monthly. And I stop it on the CRP stabilizers. I wait for about 3 months of tocilizumab because I will give, suppose, escalated dose of azathioprine, or if I change over to mycophenolate, it takes little time to act. So I give that time for the tocilizumab to control. If the patient cannot afford tocilizumab, yes, give them steroids and don't taper it for at least first 1 month, and then taper it very slowly. And I taper by 3 months to a much lower dose by the time whichever is the other agent should take care. We have seen actually the azathioprine is a very good drug. In Lucknow, it was published from Sanjay Gandhi PGI many years back that the azathioprine had even angiographic status improvement after long-term follow-up. So if patient is poor, there's no contraindication, patient is not taking azathioprine more than 5 years, you can give it because the risk of malignancy in beyond 5 years is little higher with azathioprine. The third thing is, in this case, certainly I will do an angiography because it is 5 years, if you have described this patient, it is 5 years time. So we should know by now, if you do an angiography, we will know the extent of the disease. It is better to use the same modality to compare. If you use a different modality, it may be difficult to compare. So it is also ideal to do with the same radiologist at the same place so that you can compare easily. So I will certainly give high dose steroid plus increase azathioprine or mycophenolate or tocilizumab by 2 weeks' time, cut down the steroids drastically. And if you think azathioprine is not working, you can give MMF. If not, just continue azathioprine. And then by about 3 months' time, I will take away tocilizumab completely and keep it only for on-demand use whenever there's a relapse again in future. And I will monitor with ITUS-A, and I will do 1 angiography if it is more than 5 years. Actually speaking, our patients get an angiography anywhere between 1 and 5 years once a repeat angiography, depending on the clinical condition. Therefore, the ITUS-A is very useful. You can avoid the need for angiography if you closely every 3 monthly do an ITUS-A. that will give an assessment of disease activity. In this patient, I can tell you it is surely active disease. Disease might have surely progressed, and she needs a much more aggressive immunosuppression.
Okay, sir. What is your experience with anti-TNF agents in this kind of situation?
It is also very good. In fact, I use little cautiously anti-TNF because most of the Takayashus have received high-dose steroids before coming to us, already received steroids. And we also give steroids on top of whatever second-line agent we give. So the risk of TB reactivation is relatively higher. So we have had a few patients who are refractory even after all the agents, and patient had some problem with tocilizumab. So we gave them TNF blockers. They have done well. In fact, in one patient, we also had TB reactivation. So in spite of doing all the monitoring for quantiferon and HRCT. So I would suggest that in indications where you have difficulty with giving tocilizumab or the disease is refractory to all agents, TNF inhibitors will be is not a bad option at all. And as I've shown you, the comparative study has shown TNF inhibitors and tocilizumab. Those days it was IV tocilizumab comparison showed the similar result.
And the last thing in this question is how to assess damage versus activity on imaging. Because we have to compare from the previous MR angio. But suppose we don't get a vessel wall edema.
Yeah.
Clinically, patient looks like active disease. Yeah.
It's actually a challenge angiographically to assess the damage. It is not always easy. The radiologist can only see a narrowing. They can see some evidence of fibrosis, or they can see aneurysm, which is also a sign of damage. When the disease activity progresses very rapidly, it leaves the damage in the form of aneurysm. If the disease activity progresses slowly, it causes stenosis and fibrosis. So, so in case of angiography, they can only go by this extent of the narrowing and aneurysm, and they can go for some vessel wall findings, but it is definitely more challenging. And actually speaking, 3D reconstruction CT has probably little edge over it. The most important thing is it can pick up calcifications, and calcification may be one of the important features. When there is a thickening, may not be always very easy to differentiate. Extensive thickening is a feature of inflammation, but thickening with calcification is a definite feature of damage. Apart from that, it can be really big challenge for the radiologist also to assess damage. So TADS score, although not validated, if it can be done, it may give some idea.
And any benefit of doing PET CT?
Yes, so as I told you, PET CT is the best indication for PET CT is the acute stage, early stage of disease, first time. So if the patient comes like a pyrexia of unknown origin in an early stage of Takayashu, who have very strong suspicion of Takayashu with some subtle pulse difference or BP difference, it is the best mode of investigation. It can really pick up active disease. Even other patient, for the first time, PET CT may show the extent of disease, the activity of disease with the gadolinium uptake, but FDG uptake. But in case of chronic, suppose a follow-up, you have done a PET CT or PET MRI first time, subsequent visit, PET CT and PET MRI, multiple studies, there was a systematic review. Late Dr. Justin Mason was involved in it. They have said it is not clear, there is controversy and variation in various studies on the outcome or the assessment results of PET CT or PET MRI during subsequent follow-up imaging. For the first imaging, yes. But the long-term follow-up imaging, not a good option.
Okay. And as you have told that half of the patient can have normal acute phase reactant with initially at presentation. What about the relapse part? Do they have relapse with normal acute phase reactants?
It can. So that is why the ITUS A was developed only to pick up those patients to obviate the need for angiography. In our country, it is not easy for angiography. It is expensive. It is an invasive procedure. There can be complications. It is So therefore, we wanted to develop in this. And itis A, if it is very closely followed, and if the investigator, the rheumatologist or the physician can easily read the glossary very nicely and do the itis A, it is a very good option. Even itis A, the beauty of ESR CRP is there's a grading. So we have a grade for ESR between 20 to 40, 40 to 60, above 60. CRP less than 5, 5 to 10, 10 to 20, above 20. So if you just score 0, 1, 2, 3 scores of ESR and CRP, and if you add it up with itis A, it has been found to be very sensitive, more than itis also, in assessing disease activity. So I would say that I fully agree. We cannot also do for all our patients angiography all the time. It is not very, patients do not like it also. It's very inconvenience unless the patient has to go for a procedure like stenting. At that time, they have no choice. Otherwise, I would try to do very carefully. So I would request all the rheumatologists to get familiarized with the itis. It's not at all difficult. It doesn't take much time to do it. And you can teach your juniors, you can teach your nurse practitioner who helps your clinical assistant, who is not a doctor, also to do it. So I think that is the way to assess disease activity. And ESR CRP may not rise even there. Suppose you have a new vessel involvement. Clinically, you find a new pulse loss, or there is a worsening of the blood pressure. It is a sign of activity in a patient who did not have. It cannot become damaged straight away without an activity. So in such cases, you may find quite often normal ESR and CRP. And Dr. George Joseph tells me many times when he does this procedures, quite a few patients has progressed like that. And thinking it is inactive disease, sometimes when they've done an intervention, they actually had restenosis, very high rate of restenosis. So he always refers to us. We control the disease activity. If the itis A has gone up, even if the ESR CRP is normal, we give tocilizumab or give high dose steroids, control the disease, and we do the procedure of intervention little later, unless it is a life-threatening ischemic complication like impending stroke, etc.
Then thank you, sir. Next question is, what are the two most common mimickers of Takayasu arthritis in our country? And can you suggest any clues, some clues to diagnose Takayasu arthritis patients in early pre-stenotic or asymptomatic phase?
That's a very difficult question, actually, although it is a very relevant question. I find, although tuberculosis is thought to be a cause, we have, in our experience, we found sometimes physician used to diagnose tuberculous arthritis, eventually turns out to be Takayasu only. It was just a suspicion because people think TB is more common, so it is more common. But in real life, I have seen some conditions where very practical, especially in the internal medicine setting. One is infective endocarditis. I have seen infective endocarditis with thromboembolism causing typically loss of pulse, and even there is septic emboli going to renal arteries, even hypertension, or other complications is a very important thing. Another thing of late is IgG4 disease. IgG4 disease is very easily missed out. It has got such a protein manifestation, much more than Takayasu, and it can be easily missed out, and they can have a lot of systemic features. So when you have a systemic feature in a patient with asymmetric pulse or blood pressure, I think we should look for these two conditions. I would say these two probably, to me, are very relevant differential diagnosis.
Yeah, absolutely. And sir, one basic thing, please define jaw claudication and tongue claudication, which is classification criteria for GC.
Yeah. So jaw claudication, by definition, by literal meaning, is that when you have pain in the jaw while chewing food. So that is a jaw claudication. Whereas a tongue claudication is it's a rare, but it is a much more severe warning of much more severe giant cell arthritis compared to jaw claudication. Tongue claudication is a severe pain which may be mimicking something like a herpes or other conditions, and this is a sign of impending gangrene and gangrene of the tongue, or this big ulcer in the tongue can happen, and it may be a really very serious complication. I have practically speaking suspected tongue claudication, but really not seen Anyone, jaw claudication, yes, we have seen. And the patient whom I told you, I've seen 3 patients of GCA here, more abroad. And jaw claudication seemed to be a very important finding in those patients while masticating food, they have pain. And this can be very difficult at times to differentiate from bad tooth, trigeminal neuralgia, and multiple other differential diagnoses involved in that area. So jaw claudication probably easier to suspect, but it is a broader spectrum differential diagnosis. Tongue claudication, if the patient says, you have to give a lot of importance to it, because you might lose important time and it might be lost. And if tongue has gangrene or big non-healing ulcer, it might have to be devastating surgery on the patient.
And I think if it is presenting manifestation, then making diagnosis will be very, very difficult.
Yes, that is true. Although it has been, if you see the differential diagnosis of jaw claudication, although it has been described in some other vasculitic conditions also, even ANCA vasculitis, polyarteritis nodosa also, but it is more characteristically, so basically you have to give everything value together. Unfortunately, we can't go by one thing. So if an elderly person has this feature, I would probably give more importance towards suspecting temporal arteritis. So in temporal arteritis, probably, as I mentioned in the initial algorithm from the review article, if there is a visual symptom, you have to give immediate attention, because visual loss happens in up to 30% of patients, and this is often by the physician's delay, because failure to recognize the seriousness. Similarly, they have a tongue claudication. It may be also a devastating complication. But jaw claudication may be a warning symptom for other internal organ involvement, including visual, because it also gives a warning of the distribution of the vessel, which may affect other vital organs.
Good, sir. Sir, we have discussed this thing, but I would like to hear again from you that recent to 2022 ACR classification criteria for large vessel vasculitis included Takayasu arthritis patient up to 60 years of age. So now between 50 to 60 years of age patients of probable large vessel vasculitis, patient can have both, either Takayasu or GCA. Can you highlight the differences in this age group so diagnosis can be made easily?
Actually, I'm very uncomfortable with this thing, although I'm a party to it. It's a big group, and I was overruled by the group for this particular finding. I said that I have looked into the compiled data of all the patients which they have used for classifying, and I have worked out, I have mentioned the incidence of Takayasu fulfilling criteria using gold standard angiography, etc., was less than 15% in patients. I think it was about 10% or something. I forgot, 10 or 11%. And because of that, including that, and also there was a lot of geoethnic variation. What happens is, as I have mentioned to you, Takayasu is not a young onset GCA. GCA is not an old onset Takayasu. So this particular thing will leave a gray zone between 50 and 60. So maybe all the other features you have to play importance to it. Between 50 and 60, I will probably be cautious in labeling. The biggest problem is what has come out in the last 10 years. We never knew before that the GCA involves such a wide extent of the aorta involvement. Earlier, it was thought to be only restricted. Now, GCA shows thickening of aorta all across. But the good news is GCA's damage is very little, in spite of widespread involvement. Damage is only mostly in the eye and only in the upper limb, axillary artery, etc. So that is the only thing. So if you say between 50 and 60, I am probably as uncomfortable as you, and I will probably keep under follow-up. Probably I'll go by the severity of the patient's disease. If it is very serious systemic disease, I will think more of Takayasu. If it is less severe systemic disease, more of a cranial and vascular disease in the eyes, I will probably go more towards DCA. But yes, this is a gray area.
And what is your experience of JAK inhibitors in Takayasu?
Actually speaking, honestly, there are a lot of enthusiastic reports here and there, starting with the in vitro studies in lab from to case reports to case series, and there are trials also. So there is probably going to be, this is probably going to be this thing, and some of our colleagues have done a small scale study and cohort study, and it is probably showing 50 to 60% patient are responsive, as I'm hearing from them. I myself do not use it much. I don't use much JAK inhibitors, especially after the FDA black box warning. I do not know how much of the truth of it is, but if it is a thromboembolic warning in a disease, a vascular disease where there's endothelial activation, I would be more cautious in using JAK inhibitors, whether it's arterial or Takayasu. JAK inhibitors do not only cause venous thrombosis, they can also cause arterial thrombosis. So I will be cautious, especially in the older age group. In fact, I have stopped using JAK inhibitor in people above 50, even if there is no family history of malignancy or thromboembolism. So in a disease where predominantly vascular disease, there's an inherent thrombus. All Takayasu, when they do a stenting, there is some amount of thrombosis happens because the endothelial irritation by the device. So that is why they give double platelets for some time, double antiplatelets. So I would be keeping my fingers crossed. It's always best to learn from others' mistake. So I will not be using it for some time till I'm very confident that it doesn't cause major complications like thrombosis, even if the efficacy shows to be high. Some people have found good results with leflunomide. So leflunomide is another cheap option for poor patients.
And do you start antiplatelet agents in Takayasu arthritis?
Yes, we do use antiplatelet. Actually, a lot of our patients go for procedures. So one of the things the cardiologists always put antiplatelets, but even otherwise, a little higher in the age group, little more extensive disease, we do give for some time. Eventually, we try to take it off. There is no very clear evidence to give it, although even for some statins also you have used in some patients. There is no strong evidence for it yet, but certainly biological basis is there. I always find that the evidence can be contaminated by industry influence, but biology cannot be contaminated. Biology is a truth. So I always give value to biology of a disease.
And the last question is, what are the indications of surgery in Takayasu arthritis? When do you refer patients for surgery?
Since you asked me, I will tell you of a very interesting surgery CMC Vellore used to do. Urology department to renal auto transplantation. I do not know how many of the audience knows about it. We used to have some refractory hypertension in Takayasu's, where the patient was rapidly progressing hypertension, renal impairment, and it was really 4 drugs not controlling hypertension. The urologists used to do such an excellent procedure. They used to take out the patient's kidney and take it away and move it to area where they used to reconnect to the aorta. And there is no need of any immunosuppression. It is patient's own kidney. And the blood pressure used to be controlled intra-op in the table. And all the drugs could be withdrawn. So now that we have much more procedures, Dr. George Joseph does much extensive procedures. Now we do not do it much. But earlier, when the procedures were limited, this was a good surgery. About bypass surgery, vascular surgeons used to do in the past. But nowadays, with use of aggressive immunosuppression, as you know, we give from day one steroids plus second-line immunosuppressant upfront. And we taper the steroids, so we do not taper the immunosuppressant at least for 1 year in remission. Then also we taper to a basic minimum level. We never come down below 500 milligram BD of MMF. So we use a lot of tocilizumab. So because of this now, our patients medically do very well. So the indication for surgical bypass, and it's not a biological very plausible explanation. If you do not treat the primary disease, even the bypass graft will get affected. It is not like coronary atherosclerotic disease. It's an ongoing inflammatory disease. So I will strongly discourage for a surgery, unless there is no other option, and there is a major organ being compromised. So unless we need an auto transplantation, if the urologist is confident, it's a very safe procedure. And really, I've never seen any surgery so dramatic like that in controlling blood pressure.
Sir, you have around 1,000 patients data. You have more than 20 years follow-up of these patients. Can you tell us what is the drug-free remission rate in your cohort of the patient?
That's a very good question. I always tell my students, and I strongly believe that in autoimmune diseases, maybe Takayasu may not be truly an autoimmune, it may be a little bit of autoimmune, little bit of autoinflammatory. In a chronic immunoinflammatory disease, it is all the time burning. It is never burnt out. Like in rheumatoid arthritis, if you see the literature for 30 years time, from your and my DM time and today, it has not changed. They say that maybe up to 10% of rheumatoids can be off drug, but that 10% is doubted whether they're really rheumatoid. There might have been viral arthritis which were treated. There are a lot of viral arthritis like chikungunya, can go on for 1 year and longer. So if they were treated as rheumatoid, you'll be able to stop them maybe. So the doubt of diagnosis in those cases exists. Same way, we find it very difficult to decide. So what I do is, the principle is simple. Your patient will teach you when to stop. So as I told you, steroids will taper fast. Tocilizumab and biologics are only stopgap. They're not long-term. They're only on demand afterwards. And MMF we use, some patient azathioprine, some patient methotrexate in high dose, whatever we use. Those patients, at least 1 year if the itis A is stable, we try to reduce the dose. So we have learned, what I have learned in this last so many years of my career is that the best principle is to come to the lowest effective dose when there is no relapse. So if I know a point of relapse, I again do not reduce it. And what I have learned, believe me, if I come down in an adult patient below 500 milligram BD of MMF, that is 1000 milligram of MMF or 720 milligram of MMF sodium, there is definitely bound to be relapse. So we have, I don't know, probably not even 10% patients who are off drug unless they have defaulted themselves, or when they've gone back to their physician, they have stopped. It's like rheumatoid. You have a rheumatoid doing very well, early rheumatoid. They go back to the local doctor and say, well, there is nothing. What is the need for the treatment? Stop. Lupus patient, they become completely all right. They go back to some doctors or even non-doctors, spiritual healers. They sometimes stop treatment. So you're all right. Unnecessarily, why you're taking medicine? We have had disastrous outcome of such patients. And in Takayasu, fortunately, it's not very dramatic disease. It slowly evolves. It doesn't cause gangrene, it causes slowly evolves. In spite of collaterals, we have patients who will be symptomatic. Like I give you an example. You can say Takayasu has a lot of good collaterals. Why do you have to give long-term treatment? The collaterals do not actually serve the purpose. It's like a subclavian steel syndrome. We have had a software engineer, a lady from Bangalore, about 10 or 15 years back. She came, she could not sit up. Constantly she's feeling dizzy. And Dr. George Joseph saw her arteries are blocked in such a way that her posterior circulation is being affected. And Dr. George Joseph stented to an significant extent to re-establish the circulation on optimum level. And this, of course, after immunosuppression control of disease, he also learned in a hard way. When he used to do some procedures without controlling disease, he used to have bad outcome. So this patient had recently gone to Alps mountaineering, and she climbed up to one of the top heights in the world and came back. So the lady who could not even stand up for 2 minutes, sit up, and almost left her job. So basically, what I'm trying to say that whether you can stop a medicine is only your patient will tell you. A good follow-up is very important. Good monitoring with eye test, and whenever you have a doubt, do an angiography, because nothing like angiography, whatever we do clinical examination. So once you know that, do that, we will be able to find out how wrong we can go if we are overconfident. Patient telling I'm doing well means nothing to me. Because you see, rheumatoid arthritis patients will say, I'm all right. They are courteous. They don't want to hurt the doctor sometimes also. Of course, now they hurt more than before. But still, many patients are still courteous. And they sometimes tell they are okay. But when they say okay, if you probe carefully, you examine carefully, you will find disease is active. So I think this question only can be answered by your own regular follow-up.
And what is the best time to take mycophenolate? Because you have used mycophenolate in
Yes.
super
Yeah,
patients.
I am one of the person who have replaced cyclophosphamide with mycophenolate in interstitial lung disease, in vasculitis, even ANCA vasculitis, except for very severe acute stage where you give cyclophosphamide or rituximab. Maintenance, all mycophenolate, lupus nephritis, of course. So in IgG4 disease maintenance, so it was not known to me. We are very lucky to have a very good renal unit who use mycophenolate for transplant patients, and they do mycophenolate level for all patients, both for sodium and this. So they do a trough level and they do mycophenolate MPA level. So when one of the nephrologists, very senior nephrologist, he's no more, he told me once, mycophenolate is a fastidious drug, something like D-penicillamine. Many of the people of these days will not know what is D-penicillamine. D-penicillamine, if you take with food, its absorption is 0. It just goes out in motion. Nothing else remains, nothing is absorbed. And I looked at pharmacology book. It was found that mycophenolate absorption is impaired. If you see the cross references, they are not very good. So I said, why not give a benefit of doubt? What happens if you just give it? The nephrologists have seen that the people, when they take with the gap with food, the absorption is better and the level is also better. So I have made it a routine practice to tell the patient, please space out with food before, after mycophenolate, so that you give some time, at least 1 hour time, the absorption is better. I'm yet to document. We have mycophenolate level with food. We are yet to document and do a systematic study to report this, that mycophenolate absorption. But what I've seen that many times when the patients on mycophenolate did not do well, instead of escalating the dose, if I space out with food, it works out better. So if you ask me the evidence, I don't have it. It is my own real world experience, and we somebody younger can do an organized systematic study to do that. Biological basis is strong. The absorption is definitely impaired with food.
Thank you, Debashish sir, for excellent talk. And we had plenty of questions. We discussed everything about Takayasu arthritis and large vessel vasculitis. I have a few more questions, but I will mail you these questions. Thank you very much. You spared time on this Sunday morning, and you taught us large vessel vasculitis. Thank you again. Thank you.
Thank you again. It's my pleasure to be associated with you. Thank you.
Thank you.
I value and I respect your ethics and your honesty and your sincerity. And good luck to you, your patients, and everybody. And I wish the doctor-patient this impasse ends very soon. Thank you.
Thank you.